Good morning, everyone, and welcome. So before introducing our Grand Round speaker this morning, there are a few housekeeping items. So for the audience who is here, please use the microphones to ask questions, and we are broadcasting live to our worldwide audience via Vimeo and YouTube. The recording will always be available for viewing. Please like, comment, subscribe, and share our YouTube channel. And for our viewers, if you'd like to submit a question, please text DeBakey to 37607. A few upcoming activities that we have are the cardiology for the non-cardiologist meeting that's this Saturday on May 17th. We have our pre-intern training for vascular residents on June 16th and the CV Fellows Boot Camp on August 8th. So now I get the opportunity to introduce our Grand Round speaker today, Dr. Ju Kim. He's a cardiologist specializing in advanced heart failure and heart transplantation. He completed his internal medicine residence training at the George Washington University Hospital in DC, where he also served as the chief medical resident. He went on to general cardiology fellowship also at GW before moving to Virginia Commonwealth University Medical Center in Richmond, Virginia for his advanced heart failure fellowship. He is currently an assistant professor of cardiology at the Houston Methodist Academic Institute and assistant professor of medicine at Cornell. He currently serves as an associate program director for the fellowship program here and core faculty in cardiology for the internal medicine residency program. He is also an associate medical director of the cardiac intensive care unit at the Houston Methodist Hospital and our medical center, and his academic interests include critical care cardiology, management of cardiogenic shock, use of mechanical circulatory support devices, and optimizing heart transplant-related outcomes. So we look forward to hearing Dr. Kim's Grand Rounds presentation. Thank you.
All right, good morning. Thank you, Dr. Patel, for that very kind introduction. I didn't know I had so many roles here. But it's a really privilege to be here and to share Grand Rounds today. And I'm going to be talking to you about cardiogenic shock, which, looking at the faces in the audience, I've talked to many of you about this topic in very different formats. But I've titled it Beware Stage B, the beginning of badness, a lot of B words, to try and highlight a core message, which is early intervention, early identification and intervention. And we're going to focus a little bit on that SCAI Stage B patient. But I do want to start with this quote. This is Dr. Cawley. I don't know, we do have some surgeons in the room, but Dr. Cawley was a thoracic surgeon. And he is sort of the pioneer in shock, mostly in shock trauma and emergency medicine and thoracic surgery. But he said this: there's a golden hour between life and death. If you're critically injured, you have less than 60 minutes to survive. You might not die right then, but maybe 3 days or 2 weeks later, but something has happened in your body that is irreparable. And he's talking about trauma shock in this patient. He was a military surgeon, a thoracic surgeon. But I think the concepts that he's alluding to can be applied to cardiogenic shock as well. And really, if you base it on this, the goals of cardiogenic shock management are this. You need to quickly identify and treat all the underlying causes of shock. You need to restore and maintain the end organ perfusion. We need to wean that support off, whether it's pharmacologic or mechanical support devices, once there's been adequate cardiac recovery. And if you can't wean it, then you have to think about things like advanced heart failure options, such as an LVAD or heart transplantation, if you're at a center that's capable of doing so. If you're not at a center that is capable of doing that, you need to think about transferring that patient to one that can. And I thought about just ending Grand Rounds right there and saying, that's the message. But I have 45 minutes or so. And so I figured I'd take you on a little tour, if you will, to define really the spectrum of shock patients and to highlight sort of diversity in the spectrum of shock presentations that really underlie why it's been so hard to move the needle in terms of mortality underlying shock. And hopefully we'll use a case to illustrate the importance of our early identification and this concept of accurate phenotyping of shock to optimize its chance of survival. And then we'll finish with just highlighting the importance and the role of a multidisciplinary shock team, such as the one we have here. So the pathophysiology of shock. It's a complicated diagram that's been seen and displayed on many other cardiogenic shock type of rounds and discussions in the past. But traditionally, shock is defined as an underlying etiology, such as an acute myocardial infarction, that leads to some decrement in ventricular performance. Whether it's systolic or diastolic dysfunction, leads to things like elevated filling pressures and congestion, hypoxia. But ultimately, systolic dysfunction leads to decrements in stroke volume, cardiac output, which then leads to hypotension and downstream effects like decreases in peripheral perfusion, that leads to vasoconstriction and volume retention. But there's also an inflammatory component of this, where the overall inflammation leads to increases in mediators like interleukins and like tumor necrosis factor. It ultimately leads to pathologic vasodilation, which ultimately leads to further decrements in contractility, and this spiral of decrement or deterioration of shock ultimately leads to death. But if you try to define shock, there's many different ways to define it. And one of the challenges in shock and trying to improve outcomes, I think, has been limited to the heterogeneity underlying the different definitions. If you look at this diagram, even from the scientific statements from the AHA about contemporary management of cardiogenic shock, there's a clinical definition, which is a cardiac disorder that results in both clinical and biochemical evidence of tissue hypoperfusion. But if you look at clinical trial inclusion criteria, it varies. All of them have some degree of hypotension baked into them, whether it's systolic blood pressure less than 90 or something to maintain normal tension. But the various markers of hypoperfusion can be either urine outputs or cool extremities. The shock trial, which is the seminal trial on that showed us the impact of early revascularization in acute MI shock, including hemodynamic criteria. The IBP shock trial included biochemical markers like lactic acidosis, and the heart failure guidelines from the European Society of Cardiology incorporates, again, various markers that are included in some but not the other, and this heterogeneity of just even defining shock really led to the need for a more consistent vocabulary and classification systems. And so in 2019, the Society of Cardiovascular Angiography and Interventions, or SCAI, gathered together a room of experts and came up with this consensus document to show that the cardiogenic shock lies on a spectrum. And they published this pyramid, if you will, of cardiogenic shock stages that range from A to E. And this was really predicated on both physical exam findings, biochemical evidence of shock, as well as invasive hemodynamics. And after its publication in 2019, there were multiple validation studies. And ultimately, in 2022, SCAI regathered and revised the pyramid. And the biggest difference is now with validation studies, this new version of the SCAI shock pyramid, if you will, really highlights and brings attention to the spectrum of shock. They even color shaded the pyramid to show that there's gradients of shock presentations. You may be familiar with the shock pyramid, but A through E, patients at stage A are those that are at risk of shock. So those are patients that are hemodynamically stable, they don't have any signs or symptoms of shock, but they're at risk for its development. So these are patients that came in with a large acute myocardial infarction or decompensated heart failure. And stage B patients are those beginning shock patients. And on this pyramid, and we'll highlight in a little bit, these are patients that have clinical evidence of hemodynamic instability, whether it's hypotension or tachycardia or invasive hemodynamics, that would be consistent with shock, but notably without hyperperfusion. But the classic cardiogenic shock patients have clinical evidence of hypoperfusion, according to this SCAI pyramid. Stage D patients are deteriorating, or patients that are not progressing or even deteriorating despite your initial therapies. And the patients with extremis or stage E shock are the ones with either active or impending circulatory collapse. There are other modifiers, such as the presence of cardiac arrest with concerns for anoxic brain injury that would ultimately sort of cohort those patients with SCAI stage E shock patients. But this paradigm did lead to some validation studies that show that this SCAI staging, A through E, was associated with stepwise or incremental increases in hospital or 30-day mortality in shock patients, whether it's all comers with shock or those just coming to the CICU, or even patients presenting without a hospital cardiac arrest. Why is this important? Well, if you look at places where I work, like the cardiac intensive care unit, cardiogenic shock is one of the leading causes or the indications for admission to a cardiac intensive care unit. And this is data from the Critical Care Cardiology Trials Network, or the CCCTN, that show that cardiogenic shock is among the leading causes of not only the admission, but is still one of the leading causes of mortality in that unit. And that's despite a lot of advancements that have occurred even in the CCU over the years. This is the old CCU, and Dr. Julian is often credited as being the sort of the pioneer that started this concept of a coronary care unit. So back in the 60s, if you came in with a large MI, you were prescribed bed rest and a good book to read. And the basic tenets were that Dr. Julian knew that if we had one location where you had continuous electrocardiographic monitoring that were linked to alarms that were audible and was able to trigger rapidly initiated cardiopulmonary resuscitation and early defibrillation with personnel that are specifically trained to know how to use that specialized equipment, including that nice defibrillator on the screen, in a specific unit, with nurses that were skilled and empowered to independently start resuscitation efforts, that led to good, sort of the best outcomes in coronary care. And so that was the CCU, the coronary care unit of yesteryear, if you will. But now, with the introduction of some of the novel therapies, including structural heart interventions, advancements in durable LVAD technology, and certainly the availability and widespread use of temporary mechanical support device technology, if you will, the CICU has morphed from really a coronary care unit, or a CCU, to a cardiac intensive care unit, where we encounter diagnoses that encompass both diagnoses that you may encounter in more medical ICU settings, such as sepsis or GI bleeding and neurologic injuries, as well as cardiac ones, like ischemic heart disease, respiratory failure, renal failure, heart failure in the setting of the rhythmic shock or valvular diseases. And this has really led to even a creation of a new field of cardiac critical care and staffing of cardiac intensive care units around the country. The cardiac critical care, or the cardiac intensivist, if you will, needs to be facile with both the fields of cardiology as well as critical care. And in our unit upstairs, in our CICU, we have this model of a CCU cardiologist who happens to be a heart failure trained cardiologist who works side by side with the critical care intensivist and oversees the care of patients by house staff, residents, interns, and fellows, to provide 24/7 care for cardiac intensive care patients. And really, the skill sets have to overlap between a cardiologist and a critical care intensivist, both cardiologists being facile with things like echocardiography, angiography, and management of things like ischemic heart disease or heart failure, as well as a critical care intensivist who's comfortable with not only procedures that are performed in ICU settings, but also cardiac critical care skills, such as vascular access, vasoactive medicines, PA catheter management, advanced heart failure management, and mechanical circulatory support devices. So there's been a lot of advancements, even in the way that we deliver care to a cardiac critical care population. But if you look at the patients that come into those units with shock, still a majority of patients that come to that unit are with isolated cardiogenic shock. And if you include those mixed shock patients who have cardiogenic and some distributed component, if you will, almost 80% plus are coming in with shock with some cardiac component. And if you look at even our own data at Methodist, on an average about a year's time, we have around 900 or 950 individual encounters of cardiogenic shock that come through our walls every year. Despite that, you can see overall, looking on the graph on the right, over the years, we've made some improvements in shock outcomes. Along here are, again, seminal works by folks like Dr. Hockman with the shock trials, the role of early revascularization, increasing comforts with things like PA catheters, but also temporary MCS technologies that have made some incremental benefits in shock outcomes. But even as of 2018, and our data still shows that if you come into the hospital with cardiogenic shock, your mortality risk is still north of 35%, almost 40%. So what do we do about it? So how can we actually better assess this issue and try to improve shock outcomes? Well, part of the 2022 SCAI sort of revision of the shock stages included this proposal to evaluate shock using this 3-axis model. And those three axes include not only the assessment of severity using the SCAI stages that I showed you earlier, which we'll revisit again in a little bit, but also phenotyping and looking at the etiology, as well as looking at risk modifiers, some of which are modifiable and some of which are not, including things like your age, the presence of comorbidities that you had coming into the unit, but whether you've had cardiac arrest, the presence of multi-organ failure. All of these things are needed to accurately not only identify the presence of shock, but look at what's causing the shock, phenotype it, to get an idea exactly what it is that that patient in front of you is dealing with so that we can basically tailor the therapy for the right patient, the right treatments, the right time, and the right place. So if we look at just the etiology arm of the phenotyping, there's many different etiologies of shock, but you can sort of simplify it into these 4 big groups. The 2 leading causes are acute MI shock and heart failure shock. And acute MI shock are patients who are in cardiogenic shock in the setting of an acute myocardial infarction, unsurprisingly, whether it's an ST elevation MI or non-ST elevation MI, where acute ischemia is the primary driver for shock. Heart failure shock is due to a primary sort of ventricular failure, whether it's left or right. There are secondary causes as well. These are patients with either pericardial diseases, valvular disease, arrhythmias, as well as post-cardiotomy shock, which is in the setting of cardiac surgery, which is almost an entirely different animal, if you will. But these different etiologies are important to sort of pin down because if you look at even the mortalities, they're very different. So all those shock patients, isolated cardiogenic shock patients, if you break it down based on etiology of heart failure versus acute MI, in the CCCTN, or the Cardiac Critical Care Trials Network registries, 60% of those patients are coming with heart failure as the etiology for shock, 27% for acute MI. Our data here at Methodist, we're close to almost 80-85% heart failure shock, maybe 10-15% acute MI shock. But even in the heart failure shock patients, phenotyping them even further to seeing if they're de novo shock patients or acute on chronic heart failure patients is important because survival in even those 2 groups, de novo versus acute on chronic heart failure shock patients, are different. And the survival outcome for de novo shock is actually closer to the acute MI population. So the etiology, the underlying etiology, is important for clinical trajectory. And it makes sense to a certain degree based on this nice illustration from Dr. Abraham and colleagues. But acute MI is really characterized by an abrupt presentation that leads to cardiogenic shock. These are typically ambulatory patients that all of a sudden have an abrupt event. And so the clinical trajectory of this population starts with acute loss in contractility or hypotension that leads to hypoperfusion, followed by congestion. In contrast, patients that I take care of with chronic heart failure, they have sort of this oscillating episodes of decompensation, and they may get sort of decongested and back home, and they may have a very much of a variable presentation. And once they come in with cardiogenic shock, their clinical trajectory is really leading with congestion first, then hypotension. And once all the sort of neurohormonal blockade that's keeping the compensatory mechanisms in place, when that falls apart, those patients may manifest with hypotension. And so these are actually very different patient populations. And even if you look at what happens ultimately to patients that come with acute MI versus heart failure shock, the acute MI patients, again, based on the shock trial with early revascularization, are more likely to have native heart recovery, as opposed to the chronic heart failure patients. Their outcomes may be more leading towards some sort of end organ replacement, whether it's an LVAD or heart transplantation. And if you look at just what happens to them, again, in the hospital in terms of mortality, these different phenotypes or different etiologies of heart failure or acute MI-related shock are associated with varying rates of mortality, still very much high. So now that we've broken down the etiology, not only to acute MI or heart failure, but we break it down further to STEMI versus non-STEMI, de novo heart failure versus acute on chronic, we can break this down even further. What is the actual underlying etiology of a de novo heart failure shock or decompensated heart failure shock? Secondly, what is the congestion profile? So these additional modifiers, are they coming in with primarily LV-related symptoms in heart failure, RV, biventricular? Do they have cardiac arrest? All these modifiers actually make a difference. And to sort of bring a particular attention to the presence of congestion, the congestion profiles actually make a difference. So this is data from the Shock Working Group Registry, where if you look at all comers with cardiogenic shock, and you look at just their congestion profiles, right-sided congestion was defined as a right atrial pressure greater than or equal to 12, and left-sided congestion was defined as a wedge pressure greater than or equal to 18. And if you look at all the comers, 50% of the patients that came in with cardiogenic shock had biventricular filling pressures that were elevated. And it matters because if you look on the bottom right-hand corner with those bar graphs, patients that came in with SCAI stage B or early shock were patients that are more likely to be quote-unquote euvolemic or normal right atrial pressure, normal wedge pressures. But those that had elevations in both right and left-sided filling pressures are more likely to be in advanced stages of shock, whether it's B, C, D, or E. And if you look at the impact of that congestion profile on mortality, regardless of whether you're coming in with acute MI shock or heart failure shock, in this case, congestion actually does matter because if you come in with biventricular volume overload or even just the presence of RV predominant shock, your mortality rates are much higher. This was further looked at using sort of machine learning. So they took all these hemodynamic and metabolic profiles or variables, throw them into a pot. This is an unsupervised machine learning approach, looking at clustering methods to see are there different phenotypes or clusters that have features that are very much like each other but very distinct from another. And looking at this machine learning approach, they identified 3 distinct phenotypes based on congestion and hemodynamic and metabolic profiles. The first phenotype or cluster, they named non-congested. So looking at the radar plots on the right, the cluster 1 patients are outlined in red. So the further out you are from the bullseye is higher pressures or higher numbers, closer or lower. But the cluster 1 patients had lower heart rates, lower filling pressures, and higher blood pressures compared to the others. So they deemed this a non-congested phenotype. Cluster 2 patients in green had lower heart rates compared to others, but elevated filling pressures, elevated PA pressures, elevated wedge pressures, and a lower GFR, and they presumed that this impacted, suggested renal involvement. And the cluster 3 patients had elevated markers of hypoperfusion, such as lactate, congestion, such as liver enzymes, elevations in heart rate, right atrial pressure, lower blood pressures, lower cardiac output, lower index. And they deem that these are patients with essentially metabolic effects or hemometabolic profiles. And if you looked at these different clusters or phenotypes of all comers with cardiogenic shock, you're able to identify the congested profile versus a non-congested profile versus ultimately multi-organ. And applying these clusters to the shock working group registries, both for MI and heart failure, and also doing some external validation with the Danish registry, which is an all MI patient population registry, there is a stepwise increase in mortality, in hospital mortality in shock patients between the non-congested patients versus the cardiorenal phenotype patients versus the cardiometabolic or multi-organ involvement. And this was also validated again using CICU data from the Mayo Clinic. They looked at about 1,500 consecutive shock patients that are admitted to their cardiac ICU and assigned these various clusters. And if you look, even within each SCAI stage in terms of severity, so even all the B patients or all the C patients, the more congested you are with increasing sort of biventricular filling pressures that are elevated with lactic acidosis and abnormal liver enzymes, so the cluster 3 patients had a much higher risk of in-hospital mortality with odds ratios approaching almost 3 compared to the non-congested phenotype. So that's just all the etiology and phenotyping in terms of is it RV, LV, what is the etiology, is it 5V? We haven't really even talked about the severity. And if you look at severity, to bring your attention back to this pyramid, the SCAI stage C patients, the classic shock, again, was distinguished on here by the presence of hypoperfusion. And they highlight that hypotension is usually present. But the SCAI stage B patients, the beginning patients, at least on here, are inclusive of patients who do not have hypoperfusion. The shock working group looked at this, and one of the groups that this leaves out are those normotensive shock patients, those patients that may have isolated hypoperfusion in the setting of normal tension. And so the shock working group looked at the data and tried to provide some more granular laboratory markers, and as well as this concept of treatment intensity. What do you have to provide that patient to maintain either perfusion or blood pressure? And really the difference came down to how we define that SCAI stage B patient. So whereas SCAI excluded or highlighted patients with hypotension, perhaps without hypoperfusion, in this format, if you will, the shock stages included patients with either hypoperfusion or hypotension, and used these 2 markers in terms of laboratory markers of lactic acid levels and liver enzymes to define hypoperfusion. So this is why I'm going to bring a case and see, because this is a case that just occurred here not too long ago that brought attention to this patient population. So this was a 67-year-old man who presented to Vascular, and for those that are not in the Methodist network, VOS is one of our freestanding ERs close by, came there with progressive dyspnea and cough for 4 days. The patient has a known history of heart failure with reduced ejection fraction and was on those home medications. And turns out the patient just had been hospitalized not too long ago and was discharged 5 or 6 days prior to representing at this freestanding ER. And if you look on exam, this is what the ER staff noted. Blood pressure is 134/90. Heart rate was 102. Patient was oxygenating fine on room air. But even on exam, the patient looked uncomfortable, was tachypnic, had evidence of congestion with neck vein distensions, had an S3 on exam, rales, distended abdomen, edema, EKG, sinus tachycardia with PVCs, but notably no acute ST elevation MI to suggest an acute ischemic event. And so the patient showed up at 6:30, and within the hour, he had usual baseline laboratory markers as well as an X-ray. It showed some congestion. Creatinine was a little elevated. The baseline, if you look back on the records, was about 1.2, 1.3, so a little bit of AKI. Liver enzymes were mildly elevated, but that lactic acid was checked. I'm not sure why. I'm glad it was, because that's one of the messages, but the lactic acid was checked, and he came back at 4. And so this patient, with a blood pressure of 130/90, sitting in a freestanding ER with known heart failure, has findings that are consistent with stage B shock. But if we want to look at all of the things we talked about so far in terms of etiology and phenotype, so far this patient has most likely heart failure-related cardiogenic shock that's acute on chronic and has evidence of hypoperfusion with lactic acidosis. So this is someone with normotensive shock. What is normotensive shock? People always ask, can you be in shock? You have a normal blood pressure. Well, this was even known and seen and reported back in the shock trial. Again, this is, seminal work by Dr. Hockman and colleagues looking at the role of early revascularization in acute MI shock. But they found, even in this registry, patients who had clinical evidence of low cardiac output, whether it's cold extremities or oliguria, with a systolic blood pressure that was greater than 90, that did not need vasopressor support, and they defined these patients non-hypotensive or normotensive cardiogenic shock patients. And in this particular registry, this population represented about 5 to 6% of the patients in the acute MI shock registry. But the in-hospital mortality of this population is 43%. So that's still a very high in-hospital mortality of patients who have clinical evidence of hypoperfusion in the setting of normal blood pressures. Compared to the classic shock patients or the SCAI stage C patients who in this registry had a ridiculous mortality of 66% mortality. It was lower than that, but still 43% mortality in patients with normal tension. Now, more contemporary data looking at all CICU admissions. This is from the Mayo Clinic, but they looked at ultimately 10,000 consecutive admissions to the CICU and characterized these people as to either having no hypotension or hypoperfusion in the green versus having one or the other in blue. And if you had either hypotension or hypoperfusion, then you were subdivided further to have either hypotension only, and that was defined as a systolic less than 90 or a MAP less than 60. Hypoperfusion only, which is defined as an emission lactate that was greater than 2, or oliguria, or a rising creatinine in this particular analysis. Or you had both. So the red box is that SCAI stage C patient. But the yellow and the more yellow or orange patients are that SCAI stage B patients. And if you look at in-hospital mortality on the right, clearly the patients with clear stage C shock have the worst in-hospital and CCU mortality. But if you look at isolated hypoperfusion, again, in the setting of normal blood pressure, you still had a very high in-hospital and CCU mortality. That is higher than the patient with just hypotension. And if you look at this plot, you can start from the bottom. If you have shock versus no shock, which is the bottom row, having shock is bad. You have an increased risk of hospital mortality. But if you look at shock, so the classic stage C shock with both hypoperfusion and hypotension, and compare that cohort to just isolated hypoperfusion with normal blood pressure, the odds ratios overlap. So there's no difference. So having isolated hypoperfusion in terms of in-hospital mortality risk is almost just as bad as having SCAI stage C shock. This has been validated over and over again. So this is, again, from that critical care cardiology trial network data. Consecutive ICU admissions over a 5-6 year period at multiple centers, 47 centers around the country. And they divided that population to those with isolated low cardiac output. And these were patients who had hemodynamics assessed within 24 hours of arrival, who had a cardiac index less than 2.2 without any kind of vasoactive agents or mechanical circulatory support devices. And importantly, no markers of hypoperfusion by laboratory markers or clinical assessment on arrival. On the other side of the spectrum are that class SCAI stage C shock patients with both evidence of shock with hypoperfusion, as defined as the presence of a lactate greater than 2, a GFR less than 45, or a worst ALT that's greater than or equal to 200. But importantly, that normotensive shock patient, again in orange, where the patient has markers of hypoperfusion, either by clinical evidence or more importantly by labs, but have a MAP greater than 60 or a systolic blood pressure greater than 90. Again, not requiring any vasoactive drugs or mechanical circulatory support devices. If you look at the baseline characteristics, hard to see, but there's really no clinical meaningful differences in the underlying demographics across these groups. If you look really closely, there is a little bit more chronic kidney disease in the patients with normotensive shock and SCAI stage C shock, but overall, nothing that was clinically meaningful. But if you look at their in-hospital mortality, again, we see a stepwise increase in hospital mortality compared to patients that come in even just with a low index, but no hypoperfusion, compared to SCAI shock patients with hypotension and hyperperfusion. But looking at the normotensive shock patients, again, normal blood pressures, but markers of hypoperfusion have higher rates of in-hospital mortality when you compare to those people without. And this seemed to persist regardless of the underlying etiology, whether you had an acute MI shock or heart failure shock, the presence of hypoperfusion. So that normotensive shock patient still is a very vulnerable patient with high in-hospital mortality. What happens to these people? If you bring them in and you looked at this is Sankey diagram from the shock working group analysis, but if you focus on the SCAI stage B box, at the 24-hour mark, more than half, so 54% of those SCAI stage B patients progress in some way in severity to SCAI stage C, D, or E. 9% go to stage C, but in this analysis, 43% of patients that came in with SCAI stage B shock worsened at 24 hours to SCAI stage D. That means their mortality risk is going up. It gets back to this concept of this golden hour or the golden day of shock intervention, where if that patient comes in that vulnerable SCAI stage B territory, but their shock progresses even within the first day, their in-hospital mortality is very much elevated. If you look at the table on the right, the patients that come in with B, if they just progress one stage to C, their in-hospital mortality at 25.9% number there is not any different than the patient that came in with SCAI stage C shock with both hypotension and hypoperfusion. If you start at B and you progress to D, those patients are not any different from patients that come in with C that progress to D. So all this to say that patients that may be in front of you with a normal blood pressure, if they have evidence of hypoperfusion, whether it's by clinical markers or laboratory markers, that person, that's a very vulnerable patient that is facing not only a high risk of deterioration and progression of severity of shock, but increased mortality. This is, again, one of the part of the validation studies from the original shock trials, but if you, at 24 hours, if you are able to make that patient's SCAI stage any better, you're riding a much more favorable Kaplan-Meier curve in terms of survival than if their SCAI stage stays the same or even gets worse at 24 hours. Again, highlighting the importance of early intervention for shock. And the graph on the right just highlights if you're not able to change the SCAI stage at all, or if it worsens during their hospitalization, your mortality risk or your survival rates are much worse than those patients who you're able to actually improve their shock stages. And this nicely shows that if you're able to improve their stages 1 or 2 or 3 stages, that they have a more favorable outcome. So back to our patient that came in with, again, decompensated heart failure, but there was evidence of hypoperfusion with an abnormal lactic acid despite a normal blood pressure. This is now about an hour and a half later. Patient arrives from that freestanding ER within a few hours, comes to the floor initially, but again, appropriately assessed by the house staff, the fellows, and quickly recognized that there is evidence of hypoperfusion. At this point, the exam also documents that the patient is cool on exam, clearly in more respiratory distress, that the patient gets transferred into the unit right away, and a swan is floated by the fellow overnight. And these are the numbers. So a patient with a blood pressure of 134/90 has a right atrial pressure of 22, wedge pressure is 33, and their fit cardiac output was very low, 3.2 and index 1.5, in the setting of a MAP of 104. So it tells us that now we're able to use these numbers to do additional sort of hemodynamic profiling and phenotyping, if you will. And the SVR in this case is very much elevated at 2,000. And again, going back to the phenotyping in terms of congestion profiles, this patient at this point now has SCAI stage C shock. They've been started on an inotrope. They have evidence of hypoperfusion. And their congestion phenotype is such that they have biventricular filling pressures that are elevated with end organ hypoperfusion. So even in SCAI stage C, now this is someone that's profile 3 with multi-organ involvement and shock. And the in-hospital mortality is climbing. And the way you interpret the top, the bars on the top, are the chances that that patient will reach that particular SCAI stage. Meaning, if you come in with cardiogenic shock, regardless in this case of either heart failure or MI, and you're in profile 3, you have at least 80% chance, if almost 90+% chance, that you're going to hit SCAI stage E as your max SCAI stage during your hospitalization. That's pertinent only because that comes with risk of mortality that is now greater than 50%, and that's 60% number. So this kind of brings attention to the role of PA catheters. PA catheters kind of took a beating for a while after the ESCAPE trial, but as most of you are aware, the ESCAPE trial did not include shock patients. And take some of this with a grain of salt. It's registry-based data, but if you look at the CCCTN, again, that multi-center sort of registry of cardiac intensive care units around the country, there's first of all wide variability of adoption of PA catheter use. Some centers, 8% of the time is a SWAN used. In some centers, it's up to 72% of the time. The main drivers, though, of things that are more likely to have that site use a PA catheter is if that patient requires mechanical circulatory support devices or if they had a diagnosis of heart failure. But according to their analysis, if you use a PA catheter, or the presence of a PA catheter can be associated with a lower in-hospital mortality in patients presenting with shock. Same analysis in the shock working group registry. If you use a PA catheter and use all of the hemodynamic variables and do a complete assessment, which includes assessment of right atrial pressure, the PA pressures, the wedge pressure, the saturations, having a PA catheter and using it completely is associated with actually a lower mortality in patients with cardiogenic shock. And interestingly, in the sickest population, the SCAI stage D and E patients, there was actually a stronger effect of complete hemodynamic profiling with a PA catheter. And for this patient, a PA catheter is actually instrumental, I think, because not only it gave us an idea of the phenotype of the congestion, biventricular involvement, but after the initiation of inotropes, based on hemodynamics, again, house staff trained to do this, started on nitroprusside and lowered that afterload. And within 6 hours of admission, next morning, patient's RA pressure is 6, which is 16. Your cardiac output is now 6.7. Your index is 3. Most importantly here, though, the admission lactate of 4 is quickly reversed and is down to 2. I didn't show you the 8 and 12 hours and 24-hour mark, but the lactic acidosis clears and stays down. And we know that's important. So we can use lactic acid as a marker for perfusion or hypoperfusion. And this is from the National Cardiogenic Shock Initiative, so acute MI patients. But survival, if you came in with a very high lactate, and if you look at the shock working group sort of definitions of shock severity, high lactate, greater than 5s, are again associated with SCAI stage D and E patients. But if you come in with a high lactate, your survival rates are lower. If you come in with lower lactate, your survival rate's a little higher. But what I want to draw your attention to is what happens if you are able to actually modify that at 12 to 24-hour mark. If you're able to actually improve your lactate or clear the lactate within 12 to 24 hours, your rates of survival, your odds of survival are much higher. And if you look at the trends of lactates levels and clearance among survivors and non-survivors of cardiogenic shock, there is a meaningful difference, even at that 12-hour mark. This is just one study I'm showing you, but there are other validations that have shown that if you're able to modify and clear lactates, it's associated with improved outcomes. So I would hopefully have shown you by now is that shock, perhaps we can define it a little differently. It's a cardiac disorder, results in both clinical and biochemical evidence of sustained tissue hyperperfusion, yes, like before, but it's irrespective of the underlying blood pressure. And really, the concept of time that golden hour, the golden day, I think is incredibly important because you have to suspect shock, you have to identify it, you have to phenotype it early so that you can tailor the treatment and again, to the right person, the right place, whether it's transferring from a different hospital. And shock centers can be at different levels. And the pyramid on the left shows you different levels of cardiogenic shock capabilities, if you will, at your institution. Level 3 centers, for example, being ones that are capable of diagnosing it, but they don't even have things like PCI capabilities or temporary MCS, as compared to hospitals like ours at level 1, where we have all aspects of shock care. We have a cath lab with capabilities of PCI, all forms of temporary mechanical support, both percutaneous and surgical, with heart failure specialists, critical care, cardiac surgery, interventional cardiology, and with the ability to look at exit strategies, if you will, if we're not able to wean that support off while maintaining organ perfusion. And this really highlights the role, again, with the multidisciplinary shock teams, because if you look at the role of a shock team, it's actually associated with better outcomes in terms of survival. And so again, this is data from the Clinical Trials Network. But in hospitals that have functioning shock teams are more likely to use things like PA catheters, which may allude to the fact that they're diagnosing, identifying, phenotyping shock, and targeting treatments. Overall rates of MCS use are actually lower in patients at shock centers. But if there are MCS options used, advanced options such as percutaneous impellas or ECMO are used. Advanced, they delineated as something more than a balloon pump, if you will. But the presence of a shock team at that institution was associated with improved ICU mortality in shock patients. So this gets at ultimately the main message, which is that shock care really is aimed at identifying the right patient and providing the right treatment in the right place at the right time. And that involves identification of shock, the etiology of shock, the phenotyping in terms of the acute on chronic, heart failure, de novo, acute MI, is it RV, LV, BIV, and all of those phenotyping things will help you identify exactly what case it is that you have in front of you. And knowing the importance of restoring organ perfusion and maintaining it with whatever tools you have, whether it's pharmacological or MCS, and assessing for cardiac recovery while maintaining organ perfusion is what's key into optimizing outcomes. So that's a summary. That early identification is important, phenotyping is important, and I encourage you, whether it's this institution or elsewhere, if you have a patient with concerns of shock in front of you, to activate that shock team. Here, we're available 24/7. I thought better and decided not to include our direct phone number on this for fear of broadcasting it to the world and Dr. Bimaraj getting called at 2 a.m. from Nebraska. But time is of the essence. And so thank you very much, and I'm happy to take any questions.
Well, great. So thank you, Dr. Kim. We'll pass around microphones if anyone wants to raise their hand for a question, and I'll just get it started. So you talked about phenotyping and understanding which is the hemodynamic profile of the patient, including their blood pressure and their volume status. Can you give us a basic idea in terms of how you're allocating evidence-based therapies now based off of that? Is there some type of algorithm, or are you kind of using more of a tailored approach based off of the specific patient in front of you?
I think unfortunately what we're still limited by is the lack of randomized controlled data to guide treatments for shock. So the best we can say is early identification and profiling is able to target your treatment, whether it's decongestion. So is it univentricular support you need? Do you need biventricular support? If it's an acute MI, clearly it goes to say we need to revascularize early. But unfortunately, there's not a powerful evidence-based randomized controlled trial level data to tell you that if you have this particular phenotype, you must do this, and that's associated with better outcomes. But again, that's gets to the state of where we are, is that we don't have powerful randomized controlled trial data other than the shock trial by the Hoffman on revascularization to guide our therapies.
Hey, Jude, thanks. Thank you. That was amazing overview. Just a question about the different models, for this multidisciplinary shock team. Even the level 1 shock team, they have all different type of models. It's like a spoke hop models. There's a portable unit models. There's a 24/7 in-house cardiogenic shock model. Are there any studies? Is there any models better than other one? Or what even the level 1 team should do to get the best outcome for this patient? Thank you.
I don't know of any data to say that one particular shock team model is better than another. There have been lots of different sort of models described in the literature with established shock teams. For example, if you look at the acute MI shock and ventricular arrhythmias, for example, Dr. Martin came from the University of Minnesota, where they have this mobile shock team, where they have the ambulance that goes to any cardiac arrest patient. If they're in VT, that person gets cannulated on ECMO right there, get in the mobile ECMO ambulance, if you will, gets brought back to the hospital and undergoes intervention, and then that ECMO is able to be weaned off, and they've shown very nice outcomes in terms of survival. So that's maybe one particular model. The models that I'm describing are really centered on collaboration among all the different specialties. And again, really those 4 core specialties are heart failure, interventional cardiology, cardiac surgery, and critical care. And I think the key is that when a physician, nurse, whoever identifies and suspects shock and calls the team, the importance is timely discussion and identification of that shock to say, okay, this person may be a candidate for this X or Y, and if it's an acute MI patient, I need to have interventional cardiology take the cath lab, and really get that patient on the right track. I don't know that there is any one particular model that's been proven to be superior, but I think collaboration and communication early on, I think, is what's important.
Ju, great summary of such a complex topic that we deal with every day. I completely agree about the multidisciplinary approach to this, as we do in other fields in cardiology. Again, randomized trials are very difficult in this space. Early recognition by Lactate and Swan-Ganz catheter is critical in the management of these patients. My question is about training. So as you pointed out, this is sort of crossroads of critical care and cardiac critical care. How do you train the next generation of cardiologists to specialize in cardiac critical care? I know some places have cardiac critical care fellowships. So is this a growing trend? I mean, is this something that's going to become commonplace as we see and take care of these complex patients?
Yeah, I think the demand is there. I'll tell you, just as we go through recruitment and applicants come and interview with us, one of the questions is this potential career path of going down cardiac critical care, and what is the experience, what is the training that's available. Right now, I think the CCU has really morphed into a CICU, and so a CICU nowadays, really, the bulk of the cases that the fellows encounter in training in the CICU are shock patients. And that in itself sort of encompasses familiarity with ischemic heart disease, heart failure decompensation, identification of advanced heart failure therapy as an option, facility with temporary MCS devices of all kinds. So right now in the general cardiology training, I think it's baked into the CICU experience. But to your point, even here at this institution, there is a critical care medicine fellowship that is starting. And there is going to be a path where if you have graduated from a fellowship program, such as cardiology, you have the option of doing an additional year of critical care training. And that person would then be essentially a critical care cardiologist. And there's a lot of demand for that phenotype of physicians to go and staff these types of units because they're cardiologists, but they're also very familiar with that second circle of skills and knowledge. And so, yeah, that may be the next sort of boon, if you will, of delivering critical care education on top of cardiology education to have this cohort of cardiac critical care intensivists who are going to staff and hopefully lead the field in terms of research and optimizing outcomes.
Thank you, Dr. Kim. This is like the most complicated topic for us. So my question is for like heart failure cardiogenic shock patients who are like isolated hypoperfusion normotensive group. So right now, like convincing the world to hemodynamic monitoring a patient who is normotensive with a lactate of suppose 3 is, especially in the resource setting, is gonna be like far-fetched, like goal to achieve. So do you think like these specifically like group B patient need more differentiation like B1 or B2, or just lactate and hypotension is serving enough for like characterization of these patients, we need more? And then if that is like where do you think the data lie? Is it because we see the comorbidities, these are like similar patients, it's not like who are at baseline sick. So like these stage B patient, like where do you think the data lies is like, which can help us to differentiate them? There's like B1, B2, B2 is like go to the ICU, or B1 is you can try or something like that.
Sounds like you're trying to put together a research project in the paper that's coming. But you know, the role of the PA catheter is still, there's still equipoise. And to your point, there's now a randomized controlled trial that is being run out of a group that started the shock working group, looking at the role of PA catheters and when to deploy it. Does early use, say within 6 hours of a shock admission, using a PA catheter and hemodynamic profiling, does that actually make a difference? We don't know. There's no randomized trial. It's ongoing. But there's nothing to say that that's going to definitely lead to evidence-based improvement, to your point. I think we're biased here because we're at a center where we have facility with these. We're used to these, and we know how to interpret them. We know how to actually use complete assessment to guide our treatments. So I think we're getting a little bit of a biased opinion. But is there hardcore randomized control data to say that a PA catheter is going to definitely improve your outcomes? No, this is registry-based data that I showed you. And so I think at least suspecting and looking for evidence of hypoperfusion still is key. And that can be done with something as simple as a lactate. And one of the projects that we have, or quality initiatives that's on our burner, is to incorporate widespread use of things like just a simple lactic acid measurement if you're thinking that the patient may be in shock despite normal tension. Because I think once you identify it, and you activate a team of people who deal with shock all the time, then we can start going down the path of profiling. Whether it involves a PA catheter or not, I think, as you saw in the CCCTN registry, there's wide center variability. We're probably in the middle. We're probably in the 50% range. So I'm not sure that it's really has to be that you have to take the B patient, put a swan in and say you're B1, 2, B, whatever. But I think it's just raising suspicion, checking things like markers of end organ hyperperfusion so that you can identify them early. I think that's the key.
So we have, your last slide up there shows that time is of the essence. How much time is in the essence of all of this therapy? Your discussion today was wonderful, even for a non-cardiologist, so thank you for your presentation. But the question I have is, these patients don't start time zero in the CICU. Time zero is frequently in one of our ECCs. And we had a patient that came to an ECC that took 10 hours to get from the ECC to the CICU. So the question then becomes, what can we start in the ECC? What can we do in our ED once we get them here to stretch that time a little bit, because it's going to take us a while to get a bed?
So again, I think optimizing organ perfusion. So the four sort of steps or the goals of shock management that I showed early on in the presentation was to identify the reversible causes, and then restore and maintain organ perfusion. So to your point, I think restoring and maintaining organ perfusion, that's time sensitive. So looking at markers of hypoperfusion, whether it's clinical data or laboratory data, and saying, okay, we have not only someone that is in decompensated heart failure, but now we have beginnings of shock, say with the lactate of 4 in the case that I showed you, then that should trigger a call to a multidisciplinary team so that we can review and further stratify what is the next best thing that needs to be done to restore and ultimately maintain organ perfusion wherever they may be, the level 3 centers, the ECCs down the road. I think once we're able to actually get eyes on the patient and start restoring end organ perfusion, that's the priority. And I think the time zero that you're referring to, I agree, it doesn't have to mean time zero on admission to CCU. It's time zero on presentation. And I think the longer we let end organ hypoperfusion fester, and I didn't show one of the nice graphics, but shock initially starts as a hemodynamic problem. But the longer you let it fester, it becomes that metabolic issue with multi-organ involvement manifested by markers of hypoperfusion. But once you get there, your mortality is up, and the amount of support that's required to bring that person back and restore organ perfusion is quite severe. And I think that's the key.
Well, great. Thank you so much, Ju, for a wonderful presentation. And if there are any questions, please feel free to come up at the end. So thank you, Ju.